Hey guys, welcome back to my channel, The ENT Resident. Today I'll be doing a case presentation on a very common topic that undergraduates usually get as a long case, and that is tonsillitis. So I'll be giving you a case and then discussing each of the history points and what you examine in the patient and how they all end up forming the diagnosis and how will we end up managing the patient with little bits of viva questions everywhere as we go. You can also now purchase my notes. I've added links in the description. Okay, so let's get started. Kavita, a 10-year-old female residing in Hyderabad, Hindu by religion, came with the chief complaints of difficulty in swallowing for 3 days and fever for 3 days. Now, moving on to history of present illness, patient is apparently asymptomatic 3 days back when she started complaining of difficulty in swallowing, which was insidious in onset, gradually progressive in nature, aggravated by eating cold food or drinking cold drinks, relieved by medication, and this is associated with pain while swallowing and also pain in both the ears, which had an insidious onset and mild in nature. She's also complaining of fever since the last 3 days, which is insidious in onset, continuous in nature, no chill or rigor, no aggravating factor. It is relieved on taking medications and also associated with weakness. Moving on to negative histories that you need to take here. There is no history of mouth breathing, snoring, increased daytime sleepiness, decreased scholastic performance, no history of change in voice, difficulty in breathing, headache, cough, nose complaints. There is also no history of ear discharge, decreased hearing, or any ringing sensation in the ears. In the past history, there are history of several similar episodes 2 times this year, and the last episode was about 2 months back, and 4 episodes in the previous year. And there is no history of diabetes mellitus, bronchial asthma, TB, epilepsy, no history of surgeries in the past, no history of any drug allergy. Family history, there's no history, similar history in siblings. Treatment history, there's similar complaints in the past, was treated by antibiotics and analgesics, post which she recovered. And coming to personal history, sleep is normal, appetite is normal, diet is non vegetarian, and bladder and bowel movements are normal. Now, that is all about history. So, let's discuss each point in history. So, the two chief complaints that a patient has come to you with are difficulty in swallowing and then fever for the last 3 days. So, first, let's talk about difficulty in swallowing. Now, difficulty in swallowing basically means dysphagia. So, when the patient comes to you with dysphagia, you'll first have to think about what are all the possible causes of dysphagia. So, how would you classify the different causes of dysphagia? This is a very common question that you are asked in Viva. So, we can classify it according to the type of disease it is. So, first is under congenital. Some examples are cleft lip and palate, congenital vocal cord palsy. Under infective causes, could be causes like peritonsillar abscess, parapharyngeal abscess, chronic tonsillitis, acute tonsillitis, pharyngitis. Inflammatory conditions, examples are gastroesophageal reflux disease, Patterson Brown Kelly syndrome, autoimmune diseases like scleroderma, SLE, traumatic causes like foreign body, head and neck trauma, neoplastic causes where it can involve benign and malignant tumors of the pharynx, of the larynx, of the hypopharynx, motility disorders like achalasia cardia, esophageal spasm, neurological diseases like cerebrovascular accident, Parkinson's, and there can also be some miscellaneous causes like pharyngeal pouch. So, this is obviously not a very extensive list of dysphagia. I'll definitely make another video on just the topic of dysphagia, but this will be enough to at least answer your Viva question. So, now that we know the causes of dysphagia, let's look at the next point. So, the patient said that the difficulty in swallowing actually gets aggravated by eating cold food or drinking cold drinks, and it gets relieved by medication. Now, what does this indicate? So, getting aggravated by eating cold food and cold drinks indicates the presence of some kind of inflammatory condition inside the throat. Whereas getting relieved by medication, for this, you have to find out what medication exactly the patient is having. You can ask the mother of the patient because here the patient is a pediatric patient. So obviously, they wouldn't know much about it. So if it reduces on taking analgesics, it probably indicates the presence of some kind of inflammation. And if it reduces on taking antibiotics, it probably indicates the presence of a bacterial infection. Moving on to the next point, the patient also complained of pain while swallowing, which is associated with this. A pain while swallowing, the other term for this, medical term for this is odynophagia. Now, again, it brings up to what are the causes of odynophagia that you could know. Again, I'll be classifying them and just naming a few causes for you to be able to answer in your Viva. But this is a completely separate topic to be discussed in details. So, coming to causes of odynophagia, it can be classified into infective causes, which can involve tonsillitis, pharyngitis, quinsy or peritonsillar abscess, inflammatory causes like laryngopharyngeal reflux disease, ulcerative causes like aphthous ulcer, tuberculosis, syphilis, traumatic causes like foreign body, laryngeal trauma, neoplastic causes which can include any kind of tumors in the pharynx and larynx, and neurological causes like glossopharyngeal neuralgia. So these are the causes of odynophagia. The patient has also said that it is associated with pain in both the ears, which is insidious in onset and mild in nature. So, a patient who has come to you with primary complaint in the throat is also complaining of pain in the ear. Now, what could possibly be the connection between them? What do you infer from this particular history point over here? This pain that the patient is experiencing is actually a referred pain in the ear. There is actually no pathology present in the ear, but because the ear as well as the tonsil share a common nerve supply, that is the reason why a pain in the throat has been referred to the ear in the absence of any pathology in the ear. This is called as referred pain. And the nerve that is involved over here is the glossopharyngeal nerve. So basically, the tonsil and the middle ear, they share sensory innervation from the glossopharyngeal nerve. So when there's inflammation of the tonsil, it leads to irritation of the glossopharyngeal nerve. And now this pain is referred to the ear even though the ear is structurally normal. So for that, you would obviously have to know what is the nerve supply, what is the areas of supply of the glossopharyngeal nerve. It supplies the posterior third of the tongue, the tonsils, pharynx, and the middle ear via the tympanic branch, which is also known as Jacobson's nerve. This is again a very important Viva question where you could be asked the name of the nerve, which is a branch of the glossopharyngeal nerve which supplies the middle ear, and that is the tympanic branch of glossopharyngeal nerve, also known as Jacobson's nerve. Now that we're talking about referred pain, let us discuss a few more causes of referred pain to the ear. So, obviously, glossopharyngeal nerve is not the only nerve that can cause the referred pain. There are other nerves as well. So, let's just describe them in brief. There can be referred pain via the fifth nerve, which is the trigeminal nerve. So, because trigeminal nerve has common supply to the dental areas where conditions like caries tooth, impacted molar, malocclusion can cause a referred pain. Or in oral cavity, there could be a benign or malignant ulcerative lesion. And in the temporomandibular joint, Costin syndrome or temporomandibular joint arthritis could also cause a referred pain via the fifth nerve. Next is the ninth nerve, which we already discussed, the glossopharyngeal nerve. So, in this case, there could be a base of tongue malignancy because it supplies the posterior one third of the tongue. The diseases involving oropharynx, like acute tonsillitis in this case, peritonsillar abscess, benign or malignant ulcers of soft palate or tonsils, and Eagle's syndrome. Eagle's syndrome is basically when there is a presence of an elongated styloid process, and the tip of the styloid process at that point irritates the glossopharyngeal nerve, leading to a referred pain. Third is a referred pain by the 10th or the vagus nerve. Here, conditions involving larynx like tuberculosis, carcinoma, and ulcers, and conditions involving thyroid like acute and subacute thyroiditis, Hashimoto's thyroiditis, these all can cause referred pain in the ear via the vagus nerve. Last of all, there can be another involvement which is referred pain via the C2, C3 spinal nerves. Here, causes like cervical spondylosis and Cary's spine can cause a referred pain to the ear. So this is in brief about all the different nerves which can cause a referred pain in ear, even though there is no pathology in the ear. Next chief complaint is fever. So these are the history points that we have taken over here. Let's discuss what does each of them infer. So first point is that the fever is insidious in onset, which means basically the fever started gradually over time and not just suddenly one day. It is continuous in nature, which means that the fever remains persistent throughout the day without any clear spikes and without returning to normal. So this can be very typical of typhoid fever, viral fevers, or chronic bacterial infections like tonsillitis. There is no chill and rigor. What does chill and rigor usually indicate? Chill and rigor have been seen to be more associated with pyogenic infections, malaria, or septicemia like conditions. The absence of chill and rigor usually suggests that this is a non septic, mild to moderate level of infection. For example, it could possibly be tonsillitis. There is no aggravating factor. So basically, there is no specific activity, food, or environmental exposure which is worsening the fever. This helps you rule out reactive fevers or fevers which are linked to allergic triggers. Next is this is relieved on taking medication, which means it is a responsive inflammatory process that is happening inside the body. This is again consistent with infective causes like tonsillitis. And the patient has also complained of weakness. Weakness is basically a systemic manifestation of fever, and this usually suggesting the presence of constitutional symptom, which we again see in infective or inflammatory conditions. So that is how you what you get from all the little history points that you have taken about fever. Next, let's talk about all the negative history we have taken and why is that important. So the first one is we have taken a history of mouth breathing, snoring, increased daytime sleepiness, and decreased scholastic performance. Now, why is this important? What does mouth breathing and snoring usually indicate in a patient of this age group? So, mouth breathing and snoring is a very common indicator of adenoid hypertrophy, which happens in children of this age. Secondly, it could also be an indicator of obstructive sleep apnea syndrome. Now, what happens in obstructive sleep apnea syndrome? This is actually a very complex topic to understand, but in just in short, to understand how can obstructive sleep apnea cause a lot of problems in the in patients of this age group. What happens in obstructive sleep apnea? So, first of all, when you're sleeping at night, the muscle tone which keeps your airway intact, the muscle tone actually reduces at night. Now, this coupled with any kind of obstruction that you may have, for example, like very large tonsils or the presence of adenoid hypertrophy, which is causing an airway obstruction, this combined, it leads to an airway collapse. Now, when the airway collapses, it leads to decreased oxygen reaching the alveoli. This leads to hypoxia and hypercapnia. Hypoxia meaning there is a decreased oxygen levels, and hypercapnia meaning there is an increased carbon dioxide levels. Now, this reaches the brain. So, there is an increased carbon dioxide level which starts stimulating the respiratory centers. And as a result of which, the patient ends up awakening from sleep in the middle of the night. So, the moment you wake up, your respiratory centers are very stimulated. So, you start taking deep breaths for a few minutes so as to get more oxygen in the brain. Now, as you do that, you again start to fall asleep now. And then this cycle keeps on continuing because the moment the patient falls asleep again, the muscle tone reduces, coupled with airway obstruction, leads to airway collapse, leading to hypercapnia. So this cycle keeps on continuing every night in the life of the patient. Now, this hypercapnic insult to a growing brain in this pediatric age group that leads to a very underdeveloped brain and decreased IQ. Now, this disturbed sleep over a long period of time will lead to patient complaining of increased sleepiness in the daytime. And a very another important factor in children to note is that there will be a decrease in the scholastic performance. They will not be performing as well in school. They will be sleepy, drowsy, not paying attention to classes, and their academically their results will keep going down. So that is a complaint you will be getting from the teacher of the school. where parents might come and say that that their child is actually not paying much attention. So that this should be an indicator for you to catch on and realize that probably there could be an obstructive sleep apnea syndrome going on over here. So that is the importance of taking history of mouth breathing, snoring, increased sleepiness in daytime, and decreased scholastic performance in children of this age. Now, in some adenoid hypertrophy patients, you will also see that the parents will come and complain that they are having nocturnal enuresis, which is basically they are ending up wetting the bed at night. Now, why does that happen? So, what happens during obstructive sleep apnea? There is a negative intrathoracic pressure which increases inside you. This will lead to atrial stretching, which releases the atrial natriuretic peptide. Now, the job of atrial natriuretic peptide is actually to promote diuresis, which means increased urine production. And at the same time, there is also a suppression of the antidiuretic hormone, which results basically both of this combined results in increased nighttime urine output, contributing to the enuresis. And the second problem that happens is there is an impaired arousal response in the pediatric patients. So, children with OSA have actually blunted arousal to the bladder fullness that they are having. So, they don't end up waking up when their bladder is full, leading to bedwetting. And this is a very common thing that parents will come to you and complain that these patients are typically having bedwetting scenes. So, how do you suspect adenoid hypertrophy from just looking at the patient? So, there would be complaints from the history, there would be complaints of snoring and mouth breathing, disturbed sleep, decreased scholastic performance. But if you just had to look at the patient, a very typical facies that they have is known as adenoid facies. Now, this is a very, 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 very important uh, topic from the perspective of knowing what are the features that you'll be noticing that combines to form the adenoid facies. So the features are, first of all, the patient will have an elongated face. You can see in the image over here. The elongated face happens because of a vertical maxillary overgrowth because of the alteration of the jaw development. Second, the patient will have a very dull mask-like face, which is often described as a vacant stare or an inattentive look. You'll be noticing that they are breathing through the mouth. They'll have a flattened nasal bridge because the nasal ala do not end up developing properly. So there is underdevelopment over here leading to a flattened nasal bridge. The patient will also have a pinched nose, which means they have narrow nostrils and a very nasal speech, a hyponasal voice. They'll also have sunken eyes. I've already mentioned about them breathing through the mouth. Their mouth is constantly open. This is due to the habitual mouth breathing from the nasal obstruction. As a result of the mouth breathing, they'll also end up having a high arched palate because of the improper tongue posture and mouth breathing. Next, the result of this will be a crowding of teeth in the upper dental arch. And last of all, the patients will have a very short upper lip with exposure of the upper incisors. So, all of these combined make up the adenoid facies, and this will be very important for you in picking up, just being able to diagnose just by looking at the patient what possibly they could be going from. Now, okay, so now we are suspecting that the patient has adenoid hypertrophy. Now, how do you confirm the presence of it? Because that is not a structure that you can easily see on examination. Yes, you can obviously do a posterior rhinoscopy, but it is quite difficult to actually do posterior rhinoscopy in children. Other than that, the other investigations you could do are a diagnostic nasal endoscopy under local anesthesia that will help you in finding out the presence of the adenoids, which is present at the junction of the roof and the posterior wall of nasopharynx. You can also do a X-ray nasopharynx lateral view. And last of all, during the time of surgery, you can do digital palpation under general anesthesia. Now, when you do digital palpation, what is the feeling that you feel when you are palpating the adenoids? This feeling is described as actually as if you're palpating a bag of worms. This is a very typical description that you need to remember. Next, let's talk about the next point, which is change in voice. Now, a change in voice that you could possibly have to look out for in these cases is something that is known as hot potato voice. Now, why is it called hot potato voice? This voice is something that sounds a little muffled and very thick. It resembles speaking with as if you have put a hot potato in your mouth. That's the reason it came to be known as hot potato voice. Now, some causes of hot potato voice are acute tonsillitis with very large tonsils, peritonsillar abscess, epiglottitis, Ludwig's angina, base of tongue, and supraglottic malignancy. Next history is about difficulty in breathing. Now, difficulty in breathing in these cases could actually indicate the severity of the disease and a couple of other causes. For example, if the patient has grade 4 enlargement of tonsil, which is basically also known as kissing tonsils, the patient can actually complain of difficulty in breathing because there is barely any space in between the tonsils for air to pass. And even patients with adenoid hypertrophy can complain of difficulty in breathing. Other causes could be peritonsillar abscess, parapharyngeal abscess, retropharyngeal abscess, or even in cases of subacute bacterial endocarditis, which is basically a disease which is caused by the same microorganism as that of acute tonsillitis here, which is beta hemolytic streptococcus. So these patients, this could basically be an indication of a complication of having infection with beta hemolytic streptococci. So difficulty in breathing is a very important history that you should be taking in these patients. Next is patient has complaining of headache, cough, or any nose complaints. How is this important? Headache could be possible indicator of involvement of the paranasal sinuses. Any nose complaints could also involve. It could point towards any nose pathology, which is also a source of infection in the patient. So you'd have to work on uh, removing this pathology first before you go ahead and perform tonsillectomy in these cases. And then cough. Cough is now a very huge topic. You would have to know some causes of cough that you would have to look out. What kind of cough is this? Is this a dry cough? Is this a wet cough? If it is a dry cough, it could have a lot of different causes like ENT causes, respiratory causes, cardiac causes. And ENT causes further could be like an infective cause, an inflammatory cause, any paralysis, or caused by a tumor. Infective causes could involve acute pharyngitis, acute laryngitis. Inflammatory causes can involve environmental causes, allergic cause. Paralysis can involve superior laryngeal palsy, and masses can be any benign and malignant tumors. Whereas for wet cough, the ENT causes include sinusitis, aspiration, tracheobronchitis. So this is quite a big list of the different causes of cough that could be depending on the type of cough that the patient presents to you with. Last of all, also taking the history of any ear discharge, decreased hearing, or ringing sensation of ears. What is the importance of taking this? Now, your patient has come to you with the complaint of having pain in both ears. So, it is important to know over here for you, is there any pathology in the ear itself, or is this just a referred pain in the ear? So, for that, you have to know if there is any other symptoms of the ear. So these patients can typically have two kinds of ear diseases. They could end up having an acute otitis media simultaneously, where they'll complain of a very severe ear pain. This starts usually after a upper respiratory tract infection. The patient will come to you with a very severe ear pain, very common in this age group, with fever, irritability, and crying. Second ear disease that is very common is known as serous otitis media. Now, here what can happen is if there is a adenoid hypertrophy, which leads to obstruction of the eustachian tube opening, which is located in the lateral wall of the nasopharynx. When there is an obstruction of the eustachian tube opening, there is a negative middle ear pressure that forms. This leads to the development of serous otitis media. Now, what are some other names of serous otitis media? There are multiple other names like glue ear, otitis media with effusion, non-suppurative otitis media, and non-infective otitis media. Now, pediatric patients, they'll not always be able to complain to you with decreased hearing. Now, what are certain things that will help you in understand that the patient is actually going through a complaint of decreased hearing? So, first thing would be the patient's parents. You have to listen to what the patient's parents have to say. Now, patient's parents will complain that their child does not respond always when they are called, or they end up responding after they're called multiple times. This could indicate that the patient is probably not being able to hear properly. Second, a decreased scholastic performance at school because the patient is not aware of what the teacher is teaching at school. This could also be an indicator of a hearing loss in the patient. And third would be when the parents come to you and say that the child increases the TV volume excessively. So these are all little things that you would have to be aware of so as to extract the history of hearing loss from a pediatric patient. Now, coming to past history, now the patient has complained of similar episodes 2 times this year and 4 episodes in the previous year. Why is this history important? First of all, knowing this will determine the chronicity of this condition, that this is a case of chronic tonsillitis. And secondly, it will decide whether the patient needs tonsillectomy or not. There is something which is known as Paradise criteria for tonsillectomy. We'll discuss this towards the end when we discuss the management of the patient. But that's a criteria you should know so as to understand in which patients coming to you with throat pain and fever and all of these other symptoms of tonsillitis would you choose to perform a tonsillectomy in. Now, other than this, history of diabetes mellitus, bronchial asthma, TB, epilepsy. Why is epilepsy important? Epilepsy is important from the view that sometimes tonsillitis, basically because it is an acute infective condition, it can lead to febrile seizures. So, it is important to know if the patient has any episode of febrile seizures or not, because febrile seizure in a child of this age can actually lead to neurological damage. So, in order to treat the febrile seizure, you would have to treat the cause behind it. And the cause behind it, if it is acute tonsillitis, in that case, this is a indication for performing tonsillectomy in these cases. So, a patient coming to you with tonsillitis and febrile seizure, that ends up being an indication to perform tonsillectomy. Any known history in siblings also helps you in diagnosing towards the fact that the patient could be susceptible to developing tonsillitis as well as adenitis. And next, coming to treatment history, it is very important to know whether every time that the patient has had a similar episode of throat pain and fever, how has the those episodes been treated with? Have they gone down after treating with antibiotics and analgesics? So that is a very important history to take care of. Secondly, sleep history. Why is sleep history important? I've already discussed this. When the patient starts to have mouth breathing and snoring, the sleep will actually, over a long period of time, end up being disturbed, and that will lead to increased sleepiness in the daytime. So, this is all about the history perspective. Now, let's move on to see what are the examination findings that we have in this patient. So, I'll just quickly read through this. I'll not be discussing much about the general and the systemic examination. We'll directly discuss about the oral cavity and oropharynx examination. So, the patient is alert, conscious, cooperative, oriented to time, place, person, well built, nourished, no pallor, icterus, sinuses, clubbing, edema, or any generalized lymphadenopathy. Temperature is 102 degree Fahrenheit, which is raised. The patient is complaining of fever. Pulse is 82 beats per minute. BP is 110 by 70. And respiratory rate is 16 breaths per minute. On systemic examination in cardiovascular system, S1, S2 is heard. There is no murmurs. Respiratory system, there is bilateral air entry present. Normal vesicular breath sounds are heard. In CNS, there is no focal neurological deficit and cranial nerve examination is normal. And per abdomen is soft and non-tender with no organomegaly. Now, next, let's talk about the oral cavity examination. Mouth opening is adequate, lip and oral commissures are normal, tongue is normal, floor of mouth is normal, there is no ulcer or swelling seen, opening of submandibular duct is normal. Buccal mucosa, gingivobuccal sulcus, teeth, retromolar trigon, and hard palate are all normal. Moving on to oropharynx examination, there is halitosis present, uvula is congested, soft palate is congested, bilateral anterior pillars are congested. There is a bilateral grade 3 enlargement of tonsils which are also congested. Bilateral posterior pillars are not seen and posterior pharyngeal wall is congested. Indirect laryngoscopy has not been done. Coming to neck examination, the trachea is in the midline, laryngeal crepitus is present. Single nodular swelling is felt on both sides of the neck, 1 centimeter below the angle of the mandible. The nodes are 2 into 2 centimeter in size, tender, firm in consistency, mobile in both the horizontal as well as vertical planes, has a smooth surface, and the margins are regular. Skin over the swelling is normal. There is no scars, dilated veins, or visible pulsation present. Nose and paranasal sinus examination is normal, and ear examination is also normal. So, these are all the clinical findings that we have seen in this patient. Now, we'll be discussing mainly focusing on the oral cavity and the oropharynx, as well as the neck findings that we have seen. Now, let's discuss all of the examination findings. Starting with in oral cavity examination, the first thing we spoke about was that the mouth opening is adequate. Now, when we say adequate, the next question always comes is what is the normal mouth opening? And what is inadequate mouth opening? And what is the condition called? And how would you grade that condition? So, let's discuss each one of those questions one by one. First of all, what is inadequate mouth opening? When there is a restricted mouth opening, the condition is known as trismus. Now, at this point, you will be asked the question, what are some causes of trismus that you know about? That again can be classified into different types. There could be abnormalities of teeth or the mandible, like an unerupted tooth or temporomandibular joint arthritis. There could be an acute inflammation in the temporomandibular joint region, like parapharyngeal abscess, peritonsillar abscess. There could be a history of trauma, where there could be a temporomandibular joint fracture, zygoma fracture, joint dislocation, mandibular fractures, muscle spasms in tetany, epilepsy, tumors, oral submucous fibrosis, and strychnine poisoning. So these are some of the causes of trismus. Now we'll also know about the grading of trismus. So before that, first we need to know what is normal mouth opening. When we say that the mouth opening is adequate, it means normal mouth opening is 5 to 7 centimeter. Anything below that starts to fall under the category of trismus. Now let's talk about the grading of trismus. Now, grading of trismus has been divided into 4 grades. Grade 1 is when there is a 2.5 centimeter to 4 centimeter of mouth opening. Grade 2 is when there is a 1 to 2.5 centimeter of mouth opening. Grade 3 is when there is less than 1 centimeter of mouth opening. And grade 4 when there is a nearly complete or a total trismus. That is the grading of trismus. Now, when we are talking about trismus, we are also thinking about mastication. This is again a Viva question that is very important. What are the different muscles of mastication? It is very easy to remember with the mnemonic MTP. M meaning masseter, T meaning temporalis, and P is for pterygoids. And pterygoids can be medial and lateral pterygoid. Those are the 4 muscles of mastication. And a very important confusing question and also a very important entrance examination question is, you could be asked like which one of these is not a muscle of mastication, and amongst them buccinator could be there, and buccinator, it's very easy to confuse it for being a muscle of mastication because of its location, but buccinator is actually not a muscle of mastication at all. Next is we have seen that the lip and oral commissures are normal. So what are we trying to look for when we are looking at the lips and oral commissure in these cases? First of all, we are looking for any signs of dehydration. If the patient is febrile, toxic, the patient probably is complaining of a lot of pain and difficulty in swallowing. They might not be drinking enough water or being able to eat. So you'll be able to see signs of dehydration. And this is more severe in cases of abscess like peritonsillar abscess. Second, we could be looking at angular stomatitis, cheilitis. Basically, these are indicating towards any signs of vitamin deficiency in the patient. Now, next point is looking at the tongue. Now, what are we trying to find in the tongue? A very common thing that you may end up finding in tonsillitis cases is having a coated tongue. Now, what are the different causes of coated tongue and what do each of them look like? That's also something that you would have to know. So, coated tongue, a most common cause would be just having poor oral hygiene or dehydration. These are very common causes of coated tongue in a patient who is having an infection. Other than this, there could be acute infections like tonsillitis, pharyngitis. There could be oral candidiasis, where we see a very white, creamy like patch. You can see in the image over here, this is the tongue that you see in a case of oral candidiasis. It can also be a side effect of medications like steroids and antibiotics. So, whenever you're having steroidal sprays, it is very important when steroid inhalers are given to patient in cases of asthma or COPD, it is very important that you rinse your mouth properly after inhaling the medication, because deposition of steroids over time can lead to the formation of a coated tongue, and it can also predispose you to develop a fungal infection like candidiasis. Then, also in cases of nutritional deficiencies like vitamin B12, iron, folate deficiency, you could see a coated tongue. Systemic diseases like diabetes, HIV, liver disease, and even in tobacco use. So, these are some of the causes of coated tongue. Now, next point is looking at the floor of the mouth. Now, what are some things that you look at the floor of the mouth? A very common thing that it's actually not a very common thing, but some a finding that you very commonly seen in children, and they can come to you with an impaired speech. And finding that you will find when you look at the floor of the tongue is that there is a presence of tongue tie. Now, what is tongue tie? Tongue tie is a condition which is also known as ankyloglossia. Now, tongue tie is a condition where basically you will see over here, this is a frenulum linguae. Usually, the frenulum linguae is longer than this. So, whenever there is a shortened frenulum linguae, the patient is actually not able to protrude their tongue easily. And this, the main problem that the patient or the patient's parents will come to you with is having a speech difficulty. Now, even ankyloglossia, for ankyloglossia, you would have to know what is the grading of ankyloglossia. There is a Kotlow's classification which has graded ankyloglossia. For this, in class 1, when there is a free tongue length of more than 16 millimeter, and this is normal. Class 2 is when the free tongue length is 11 to 15 millimeter. This is known as mild ankyloglossia. Class 3 is when there is a free tongue length of 7 to 10 mm, and this is known as moderate ankyloglossia. Class 4 is when there is less than 7 mm of free tongue length, and this is known as severe ankyloglossia. So, this is a little bit about ankyloglossia, which is a very important Viva question that you may be asked. Next, in the floor of the mouth, can you name a swelling that you usually look in the floor of the mouth? This swelling is known as ranula. Now, what is ranula? Ranula is basically a mucus extravasation cyst. What happens here is when there is a rupture or obstruction of a salivary gland duct, most commonly the sublingual gland, mucus leaks into the surrounding tissue, and it leads to the formation of a mucus extravasation cyst, which is known as ranula. The word ranula means frog's belly. And the reason why this is called is the ranula appears like a frog's belly, which is basically a bluish, translucent, dome shaped swelling, and is usually seen in the floor of the mouth, like we see in the image over here. And another little question that you had to know is ranula can be of two types. One is a simple ranula, when the ranula is just confined to the floor of the mouth, as in this image. And the second is a plunging ranula, when the ranula extends through or around the mylohyoid muscle into the neck. So there will be two swellings, one in the neck and one in the floor of the mouth, like this. So these are the two types of ranula. And when you're asked about treatment of ranula, never say excision. The treatment is actually marsupialization. Next, Buccal mucosa. We have said that the buccal mucosa is normal. Now, what all things would you be looking for in the buccal mucosa? We look for the surface and color. We look for any pre-malignant lesions of the oral cavity. If there is any candidal patch, like I have shown you before on the tongue, if there is any ulcer present, which can be traumatic, malignant, aphthous ulcer, if there is any pigmentation present, if this is obviously not applicable in a case of pediatric age group, but in an adult, you'll look for nicotine stains and betel nut stains. Now, I just mentioned about pre-malignant lesions of oral cavity. Can you tell me some pre-malignant lesions of the oral cavity and what do they look like? The four common ones are, first is leukoplakia, where we basically, you can see in the buccal mucosa over here, we see a whitish patch over here. Second is erythroplakia, which is a reddish patch that you see. Third is a combination of erythroleukoplakia, where you see a reddish as well as a whitish patch. And fourth is oral submucous fibrosis, where basically there is fibrosis happening in the submucosal tissues and there is reduced mouth opening in these cases. So these are the common pre-malignant lesions of oral cavity that you gotta know about. You should definitely study more on this because each of these topics can be a short note for you. Next, coming to teeth. Why is looking at teeth important in tonsillectomy cases? This is very important because you should definitely look out if there is any loose tooth in the patient. Because in these patients, when you perform tonsillectomy, to open up the mouth and fix it, we usually use a Boyles and Davis mouth gag. When you are using the Boyles and Davis mouth gag, if you have seen this happen in your OTs, you'll see that it can easily, if there is any loose tooth present, you can easily end up dislodging the tooth. Firstly, this may be a problem from the perspective of if the tooth gets aspirated by mistake, if there is no throat pack present or anything, if you're not aware of it. Secondly, the patient's parents might come to you and say that, my child did not have a loose tooth and you ended up causing this. So you should be aware if there is loose tooth already in the patient and inform their parents before you're taking the case up for surgery. Next is the retromolar trigon. Now, what is retromolar trigon and why is it important to look at this area? So, retromolar trigon is basically the triangular area that you see behind the last molar. You can see in the image over here, this is the last molar. The triangular area that you're seeing behind it is the retromolar trigon area. And this area is very important to be seen because this is actually a hidden area in the head and neck. And also, secondly, when there is a malignancy involving the retromolar trigon area, it can actually end up involving the mandible early because the mandible is in close relation to this area. And the moment mandible gets involved in a malignancy, this actually upstages the disease. So this will end up being stage 4 of malignancy, which is actually very advanced. So that is important of looking at the retromolar trigon area because this is an area that can be very easily missed. Now, I said that this is a hidden area in head and neck. That will lead you to the question of what are all the other hidden areas in head and neck. Some other hidden areas other than retromolar trigon are the floor of the mouth, tonsillolingual sulcus, which is the groove between base of tongue and tonsil, fossa of Rosenmuller, lingual surface of epiglottis, anterior commissure of vocal cords, subglottic region, piriform sinus, especially its apex, and the postcricoid area. These are all the hidden areas of the head and neck. Now we come to oropharynx examination. Now, we have seen that the patient has a bilateral grade 3 enlargement of tonsils, which are also congested. Now, once you've seen a grade 3 enlargement, a lot of times in undergraduate, what we end up doing is because we are just following this pro forma of writing down what are the points we are noticing, whether we see it or not, we end up writing that bilateral posterior pillars are congested. But it is very important to be smart over here and remember this, that if you have mentioned that the patient either has a grade 3 or a grade 4 enlargement, in this case, you'll actually not be able to view the posterior pillar because of the size of the tonsils. So, you should definitely not write what you have not seen. In this case, you should, in for grade 3 and grade 4, the bilateral posterior pillars will not be visible. Okay. Now that we have talked about the grade 3, grade 4, let's discuss more in details what are the different grades of tonsillar enlargement. This is invariably going to be asked to you if you do end up getting a case of tonsillitis as a long case. So there is a grading which is known as Brodsky grading of tonsil enlargement. If you see in 0 over here, the tonsils are within the tonsillar fossa. In grade 1, the tonsils occupy less than 25% of the oropharyngeal width. This is the oropharyngeal width. In grade 2, the tonsils will be occupying 25 to 50% of the oropharyngeal width. In grade 3, it will occupy 50 to 75% of the oropharyngeal width. And grade 4, you'll see it'll occupy more than 75% of the width, or they'll probably be almost kissing because both the tonsils will be almost in contact with each other. This is also known as kissing tonsils. So this is the grading of tonsil enlargement that you need to remember. Next is, say a patient, usually we do end up seeing a bilateral tonsillar enlargement, but say a patient has come to you with a unilateral tonsillar enlargement. Now, what could be the differential diagnosis in these cases? This could be a case of tonsillolith. A tonsillolith is when basically the crypts in the tonsil can get studded with food material and which ends up calcifying. That is known as tonsillolith. It can be a tonsillar cyst. A tonsillar cyst is formed when a crypt gets blocked and the minor salivary glands which are present on it, the minor salivary gland secretion starts to accumulate and leads to the formation of a tonsillar cyst. There could be another important cause, very important cause, is a peritonsillar abscess. We see a unilateral tonsillar swelling and the uvula being deviated towards the opposite side. Patient coming to you with fever, a lot of throat pain. That will be a case of peritonsillar abscess. Very rare cause is a tonsillar malignancy. There could also be a parapharyngeal abscess or a tail of parotid tumor. Let's look at some images of what these looks like. First image you can see is a case of tonsillolith. You can see calcification happening over here. Second image over here shows the presence of a tonsillar cyst, which looks more like it's an accumulation of some kind of secretions inside. This is what a peritonsillar abscess will look like. You can see that the uvula gets deviated towards the opposite side. And usually in these cases, you take an incision in the most bulging part of the abscess. And this second image over here is showing how a tonsillar malignancy looks like. This is actually a very rare occurrence. Now, another entrance level examination question is, where do you see orange colored tonsils in? And this disease is known as Tangier's disease. Tangier's disease is a very rare inherited disorder which is autosomal recessive pattern of inheritance. This is a disorder of lipid metabolism where you have extremely low levels of HDL in it. So this name is very important to remember. This is a very common PG entrance exam question. Next is, we said that we have not been able to perform indirect laryngoscopy because when a patient has come to you with throat pain and fever, especially in the pediatric age group, the patient is not going to cooperate with you to perform an indirect laryngoscopy. So you should definitely not lie and mention that you have performed indirect laryngoscopy in these cases. Now that we're talking about indirect laryngoscopy, let's learn first of all, how do we perform indirect laryngoscopy and what do we see in here? So the difference between performing indirect laryngoscopy and posterior rhinoscopy is, in indirect laryngoscopy, you pull out the tongue, you ask the patient to protrude the tongue and you hold it with the help of a gauge with your left hand. Whereas in posterior rhinoscopy, you use the Lux tongue depressor in your left hand to depress the tongue while you enter the mirror. That is a key difference that you need to remember and do not forget it, because your examiner may actually try to confuse you while asking how is the procedure done. So in indirect laryngoscopy, first you explain the procedure to the patient. Then you tell the patient to sit upright with the head slightly extended. You warm the laryngeal mirror so as to prevent fogging when you introduce into the oral cavity. Ask the patient to protrude the tongue and you hold it with the gauge with the left hand. Then, with your right hand, you hold the mirror and you insert it into the oropharynx. You lift the uvula without touching the posterior pharyngeal wall, and then you direct the light onto the mirror to reflect the image of the larynx. You ask the patient to say E to see the vocal cord movement. These are the steps of performing indirect laryngoscopy. Now, how do you prevent fogging of mirror when you are introducing into the oral cavity? There are multiple ways to it. The easiest way is dipping the mirror in warm water. You could also rub the mirror over a flame or spirit lamp. Or you can also rub, when you don't have any kind of other options available, you can rub the mirror surface on the buccal mucosa and generate heat by friction. You can dip mirror in defogging solutions like cetrimide, commonly known as Savlon. You can, I've already mentioned the buccal mucosa point. So these are the 4 ways that you can prevent fogging of the mirror before you introduce into the oral cavity. Now, what are the structures you'll be seeing in case of indirect laryngoscopy and how would you represent it? I already have a video on how to draw the structures on indirect laryngoscopy. You can check that out over there. Now, what are the difference between ideal mirror, which is indirect laryngoscopy mirror, and the posterior rhinoscopy mirror? Just as you need to know the difference between performing the procedure, this is also important. The ideal mirror is actually a larger size of the mirror. The mirror size is usually 10 to 12 in size, in diameter. Whereas posterior rhinoscopy mirror is typically smaller, about 5 to 10 diameter. The ideal mirror is actually a straight mirror, as you can see in the image over here. Whereas posterior rhinoscopy mirror is actually bent at an acute angle, typically 45 to 60 degree. The length of the shaft in ideal mirror is shorter than that of posterior rhinoscopy mirror. These are the differences in identifying the ideal mirror from the posterior rhinoscopy mirror. Now, as you're performing indirect laryngoscopy, there are certain blind sites that you are not able to see at all or you're not able to visualize properly. This is also a very common Viva question in your practical exams. These sites include vallecula, laryngeal surface of epiglottis, anterior commissure, undersurface of the vocal cords, laryngeal ventricles, apex of piriform sinus, postcricoid area, and subglottis. Next, let's talk about what we have found in the neck. We found that there was a single nodular swelling which was found on both sides of the neck, 1 centimeter below the angle of the mandible, which is basically the position of the level 2 or the jugulo-digastric lymph nodes. The nodes are 2 into 2 centimeter in size, which means that it is enlarged. Usually a cervical lymph node which is more than 1 centimeter in size is termed to be pathological. The nodes are tender, which means there is an acute condition involved over here. It is firm in consistency, mobile in both planes, smooth surface and margins are regular, and skin over the swelling are normal. Now, what does having a tender lymph node over here indicate? It indicates, first of all, that there is an acute infective stage, and second, the presence of having enlarged lymph nodes is seen as a chronic tonsillitis when there is no exacerbation. But when there is an acute exacerbation of chronic tonsillitis, you'll see not only enlarged lymph nodes but also tender enlarged lymph nodes. So that is the importance of seeing tender lymph nodes over here. Now we have discussed everything about the clinical examination as well as the history of the patient. Now let's summarize the case, come to a provisional diagnosis, discuss why is that our diagnosis, and then we'll move on to management. So a 10-year-old female came with the complaint of difficulty in swallowing and fever since last 3 days. Difficulty in swallowing was insidious in onset, gradually progressive, aggravated by eating cold food, cold drinks, and relieved on medication. Associated with pain while swallowing and pain in both ears. Has similar history 2 times this year and 4 episodes in the previous year. Patient is also complaining of fever since last 3 days, which is insidious onset, continuous nature, no chill or rigor, no aggravating factor, relieved on taking medication, and associated with weakness. On examination, there is a grade 3 bilateral enlargement of tonsils with congested anterior pillars and uvula, soft palate, and posterior pharyngeal wall. A single nodular swelling is seen on both sides of the neck, and I've already described this. So, this is our summary of the case. Now, what is your provisional diagnosis at this point? My provisional diagnosis here would be an acute exacerbation of chronic tonsillitis case. Now, when I have said this, I also need to justify why did I say each one of these words. So, first of all, when I have said acute exacerbation, what are the points which is in favor of this? First of all, the point in favor from history is the patient has come to you with a history of fever. Fever will be seen in acute infective conditions, not in chronic conditions. Also, at the same time, patient has complained of difficulty in swallowing and pain while swallowing, along with the fever. The patient has also come to you with a history of bilateral ear pain and constitutional symptoms like weakness. So, these are all the history points which are pointing towards an acute exacerbation. And when I've examined the patient, I've seen that there is a congestion present in the uvula, soft palate, anterior pillar, tonsils, as well as the posterior pharyngeal wall. So, all of this is pointing towards some kind of acute inflammation happening. And last of all, we have also seen tender enlarged jugulodigastric nodes. So, these all points point toward the fact that there is an acute exacerbation happening over here. Next, what are the points which favor the diagnosis of chronic tonsillitis? First of all, the age group of the patient. This is a very common age group for chronic tonsillitis. Second, we have seen that there are recurrent episodes of throat pain and fever in the last 2 years in this patient. Third, we are seeing a bilateral grade 3 enlargement of tonsils, which is pointing towards tonsillar hypertrophy. And we have seen some cardinal signs of chronic tonsillitis. Now, this brings us to the question, what are the 3 cardinal signs of chronic tonsillitis? So, you need to at least have 2 of these signs for you to be able to diagnose it as chronic tonsillitis. First sign is flushing of anterior pillar, where basically the anterior pillar appears a little pinkish because of the increased vasculature in this area because of presence of chronic infection. Second is Irwin-Moore sign. If you see in the image over here, you're seeing some pus or cheesy material coming out of the tonsils. So what happens here is Irwin-Moore sign is positive when you when you put pressure on the anterior pillar over here, it expresses frank pus or cheesy material from the tonsil. That is known as Irwin-Moore sign. We have not been able to perform it in this patient because the patient has complained of pain, throat pain, and patient is also febrile at the point. So in these cases, you will not end up performing Irwin-Moore sign because the patient will not be cooperative. And that is also something that you should mention in your clinical examination. Third is when there is a persistent jugulodigastric lymphadenopathy, which is non-tender. So these are the 3 cardinal signs of chronic tonsillitis. Whenever there is at least 2 of them present, it can be diagnosed as a case of chronic tonsillitis. Now that brings us to a question, which is what are the different types of acute tonsillitis? Acute tonsillitis, there are 3 types over here. There's acute follicular tonsillitis, acute parenchymatous tonsillitis, and third is acute membranous tonsillitis. Now, in acute follicular tonsillitis, what happens is the infection spreads to the different crypts of the tonsil. The crypts get filled with purulent material and they start appearing as these yellowish spots that you can see over here on the opening of the crypts. This has a very follicular-like appearance. That is why it is known as acute follicular tonsillitis. Second is acute parenchymatous tonsil, when here the whole of the tonsil is involved and it is inflamed. So the tonsil gets uniformly enlarged and red. So this is the appearance of acute parenchymatous tonsillitis. Third is acute membranous tonsillitis. Here, what happens is there is exudation from the crypts which start coalescing with each other. This could be of the next stage of acute follicular tonsillitis. And these crypts, this cheesy material that has come out, they coalesce and form a membrane on the surface of the tonsil. Now, the next question over here would be, how would you differentiate in between a true membrane and a false membrane over here? Is the membrane that has formed over the tonsil a true membrane or a false membrane? Now, these are the distinguishing features over here. First of all, a true membrane. What is a true membrane? A true membrane is one where the exudates firmly adherent to the underlying tissue, whereas a false membrane is loosely attached over the mucosa. A true membrane, when you try to remove it, the underlying mucosa will start bleeding, whereas the false membrane, it will not bleed and it will come off very easily. Common causes of true membrane are diphtheria, bacterial tonsillitis, fungal infections, whereas false membrane, it could be a streptococcal tonsillitis, infectious mononucleosis. The appearance of a true membrane is usually grayish white, thick and opaque, whereas a false membrane appears yellowish white patches or like a coating. Underlying mucosa in true membrane could possibly be ulcerated or necrosed, whereas in false membrane it is intact. The importance of true membrane is that it signifies the presence of an invasive infection, whereas in a false membrane it suggests surface exudate from inflammation. So this is how you'll be able to differentiate between a true membrane and a false membrane. Now that we are talking about membrane over the tonsil, very important question which I'll definitely make a separate video about and talk in details is, what is the differential diagnosis of membrane over tonsil? It could be a membranous tonsillitis, diphtheria, as you can see in the image over here, Vincent angina, candidiasis, infectious mononucleosis, egg granulocytosis, which is a very rare condition, leukemia, aphthous ulcer, traumatic ulcer, and tonsillar malignancy. I'll definitely make a separate video on this and discuss more in details what are the different features you'll be seeing in each one of these cases. Next is, what are the complications of acute tonsillitis? First of all, most likely answer is it can lead to the development of chronic tonsillitis. There could be a peritonsillar abscess, parapharyngeal abscess, cervical abscess, acute otitis media, or systemic complications like rheumatic fever, acute glomerulonephritis, subacute bacterial endocarditis. So, these are all the complications of acute tonsillitis. Now, tonsils, you should also definitely know about the anatomy of tonsil over here, because very easily your Viva questions can go towards the anatomy, where you may be asked about the blood supply of tonsil, what are the different surfaces and the different bodies of tonsil, etc. Now we know that tonsil is a part of a structure which is known as the Walde's ring. What are the other different structures which is a part of Walde's ring? Now Walde's ring has an outer ring and an inner ring. Now, the outer ring comprises of the retropharyngeal nodes, jugular digastric nodes, jugular chain of nodes, submandibular nodes, and submental nodes. Whereas the inner ring consists of not only our palatine tonsil, but also the nasopharyngeal tonsil, which is also known as the adenoid, tubal tonsil, and lingual tonsil. So these are the structures of the Walde's ring. I have a separate video on Walde's ring. You can definitely check it out over there. Next, coming to structures of tonsil bed. This is also a topic that I've covered in a separate video. When you're asked about the structures of tonsil bed, it is very difficult to remember because there are so many structures involved. So I have a mnemonic that will help you remember. You can check out my video for that. So when you're describing the different structures of the tonsil bed, it is very important that you go in a particular direction, either medial to lateral or lateral to medial, and not say all of random structures, whatever you're able to remember. So here you can see in the image, if we go from medial to lateral, you can see there is a capsule of the tonsil. This is the tonsil over here. This is a capsule of the tonsil. The loose areolar tissue containing the paratonsillar vein, pharyngobasilar fascia, superior constrictor muscle, buccopharyngeal fascia, medial pterygoid muscle, ramus of the mandible. Then there is facial artery, glossopharyngeal nerve, styloglossus, and the submandibular gland. You can check out my video to see the mnemonic that will help you remember the different structures of the tonsil bed. Next, coming to the last phase, how will you manage the case? So you have to remember, I've said it in my previous case presentations as well, management will always comprise of investigations and treatment. So whenever you're asked management of the case, we usually end up jumping to saying the treatment, whereas that is actually a wrong answer. Management is first investigations and then treatment. So coming to investigations, what are some investigations you'll do in this case? First of all, we'll do some routine tests and I'll tell you the importance of these tests. You'll have to do a hemoglobin because this is important to know that a contraindication of performing tonsillectomy is having a hemoglobin of less than 10 gram percentage. Next, we'll do a bleeding time and a clotting time. This will help you in finding if there is any bleeding diathesis in these patients. That can be a contraindication. Then we'll look for random blood sugar to rule out diabetes. Viral serology, where we do a HIV and an HBsAg test. This is done more as a universal precaution. We'll do a urea and creatinine. This will help you in ruling out if there is any post-streptococcal glomerulonephritis because that can be a very common complication of acute tonsillitis. We'll do a chest X-ray to rule out any pathology in the lungs and an ECG to rule out any cardiac pathology because these patients can also have subacute bacterial endocarditis or they can have rheumatic heart disease. So these are all routine tests that you need to do when you are preparing the case for tonsillectomy. If you have suspected the presence of any adenoids, in that case, you should do a X-ray nasopharynx lateral view. This will help you rule out adenoid hypertrophy. And a third, less important test, but I'm just mentioning it for you to know, be aware of it. You can perform a throat swab for culture sensitivity when you're seeing that antibiotics are not helping in resolving the disease. In that case, the culture sensitivity report will help you in deciding which antibiotics will help the patient. Next, if you see, this is the X-ray nasopharynx, and you can see in the image over here, this is the adenoids, which is present at the junction of the roof and the posterior wall of the nasopharynx. This is adenoids. That is where you'll look for. Next, let's talk about what is the most common bacteria that we isolate in such cases. And that is group A beta hemolytic streptococcus. This is the most common bacteria causing acute tonsillitis. Now, how will I treat the case? First of all, because this is an acute exacerbation, we'll first have to treat the infection. We'll not straight away jump to tonsillectomy. So first we'll treat the infection, and after the infection gets resolved, then we'll plan a tonsillectomy. So how will we treat the infection? We'll start the patient on antibiotics. If the antibiotics are not working, based on culture sensitivity report, we could change it. We'll give analgesics and antipyretics to deal with the pain as well as the fever. Antiseptic mouth gargles. We'll tell the patient to drink plenty of fluids. And after all of it has been resolved, we'll perform a tonsillectomy under general anesthesia after 4 to 6 weeks of resolving of the infection. Okay, next let's talk about tonsillectomy. What are the different questions you'll be asked? So, first, I was already discussing somewhere before in the case that there is something known as Paradise criteria for tonsillectomy that you need to know. Now, what is Paradise criteria? According to this criteria, a child is eligible for tonsillectomy if they have had a minimum frequency of sore throat episodes, which is more than equal to 7 episodes in past 1 year, or more than equal to 5 episodes per year for the past 2 years, or more than equal to 3 episodes per year for the past 3 years. Along with this, each episode must be documented and include sore throat and one or more of the following, which is either there is a fever of more than 38.3 degrees Celsius, cervical lymphadenopathy, which is tender or more than 2 more than equal to 2 centimeter, presence of tonsillar exudate, or a positive group A streptococcal culture. This is the Paradise criteria for tonsillectomy. Now, what are the indications of tonsillectomy? This is a very common question that you will be asked. So, first of all, there is a recurrent infections of the throat where you either have 3 episodes per year for 3 years, or 5 episodes per year for 2 years, or 7 or more episodes in 1 year, or you can miss 2 weeks or more of lost school or work in a whole year. Other than this, other indications include peritonsillar abscess, tonsillitis causing febrile seizure, tonsillar hypertrophy, which is causing sleep apnea, dysphagia, interference with the speech, a suspicion of malignancy when you see an unilaterally enlarged tonsil, or tonsillectomy actually can also be done as a part of another operation. For example, in Eagle syndrome, when you have to remove the elongated styloid process, in glossopharyngeal neurectomy, and in uvulopalato-pharyngoplasty, which is done in sleep apnea syndrome. Now that we know the indications, we also need to know what are the contraindications for tonsillectomy. I've already mentioned this. When there is a hemoglobin of less than 10 gram, it is actually a contraindication for tonsillectomy. Second, an acute exacerbation. We usually do not perform a tonsillectomy in those times because, first of all, there will be more chances of bleeding because of infection. And secondly, there may be a fear of bronchospasm as a result of the URTI. This will be more difficult to control during the surgery. That is why you try to avoid any acute exacerbations. Third is in bleeding diathesis, like von Willebrand disease, leukemia, etc. In children under 3 years of age. So, usually 3 years is required. The Walde's ring, as you know, is a collection of lymphoid tissue that gives immunity to the children. And it is important to give at least 3 years during which immunity develops in the patient. So, usually we'll try to avoid surgery in children in less than 3 years. Any uncontrolled systemic disease is a big contraindication for tonsillectomy, like diabetes mellitus, cardiac disease, hypertension, asthma, submucous cleft palate, and lastly is epidemic of polio, which is obviously not a cause nowadays, but that could be your last point when you mention the contraindications for tonsillectomy. Now, is bleeding diathesis an absolute contraindication for tonsillectomy? No, it's actually not. So, if you definitely need to perform a tonsillectomy in these cases, what you can do is you'll find out what the deficient factor over there is and you transfuse the deficient factor first. And second precaution that you'll need to do is you should take a different method of tonsillectomy and not use the common dissection and snare method. Because in dissection and snare method, it actually causes more injury and bleeding. So, you should use other methods of tonsillectomy. So that brings me the question, other than dissection and snare method, which is a common method followed in most places, what are the other methods of tonsillectomy or other techniques of tonsillectomy? So techniques of tonsillectomy can be divided into cold methods and hot methods. Cold methods, the most common one is dissection and snare. Other than that, there's guillotine method, intracapsular tonsillectomy with debrider, harmonic scalpel using ultrasound, coablation, which is a plasma mediated ablation. This has become a very common technique nowadays. And then there's cryosurgery. Hot methods are the methods in which you use temperature as a mode of dissection. There can be electrocautery, laser tonsillectomy, or radio frequency. Next, let's talk about the different types of tonsillectomy. What do you know what is hot tonsillectomy and what is interval tonsillectomy? So, hot tonsillectomy is when you perform an immediate tonsillectomy during an active infection, which is usually a contraindication, especially during a peritonsillar abscess. The disadvantages of performing a hot tonsillectomy is that during the time of an infection, there will be more chances of bleeding. The abscess can actually rupture and completely destroy your surgical field, and it can also lead to aspiration pneumonia from the pus that is released. The other type is known as interval tonsillectomy. Now, interval tonsillectomy is when you perform the tonsillectomy 4 to 6 weeks after an episode of an infection. That is after the peritonsillar abscess has resolved. The advantages of doing this is that there will be less bleeding and better recovery in the patient. Now, coming to more of how to perform tonsillectomy, I'll definitely make a separate video discussing tonsillectomy more in details. We'll just touch on a few points over here. The position for tonsillectomy is known as the Rose's position, and you will be definitely asked to describe the Rose's position. So, in this position, the patient lies supine, and you place a sandbag or a head ring under the shoulders. This will cause a neck extension and slightly tilt the head backward. So the extension is basically happening at the atlanto-occipital joint. So this is Rose's position. Now moving on to steps of tonsillectomy. In very quickly, if you had to say, first of all, you'll introduce Boyles and Davis mouth gag and open the mouth and hold it in place using Graffin's bipods. Then you place the throat pack. You hold the tonsil at the upper pole with tonsil holding forceps and pull it medially. Make an incision in the mucous membrane where it reflects from tonsil to anterior pillar. Then tonsil is dissected from the tonsillar bed using a Mollison's dissector. Once you have reached the lower pole, use the Eves tonsillar snare at the lower pole. You crush it and cut the tonsil and ensure hemostasis. If there are any bleeding points, you control them and then you repeat the steps on the opposite side. So this is your tonsillectomy steps in quick points to remember. Next, after you have performed the tonsillectomy, how would you do a post operative care of the patient? First of all, the patient will be ready for discharge within 24 to 48 hours maximum. You'll ask the patient to have a lot of ice cream. Usually, children will definitely like that. You'll probably end up promising the patient that if they go through the surgery, you're gonna give them ice cream. But there is actually a scientific reason behind it. Having ice cream will have a vasoconstrictor effect, so it will lead to less bleeding, and this will also help in soothing the pain that the patient will be experiencing. So at this time, you'll also tell the patient's parents to avoid hot and spicy food. You'll give antibiotics for 5 to 7 days, analgesics for 2 to 3 days like ibuprofen or paracetamol. If the patient is really young, you should be giving it in syrup rather than tablet form. And you'll also tell the patient to do diluted hydrogen peroxide gargles, which will help in removing whatever slough is forming in the tonsillar fossa. Now, say the patient has come back to you after 4 to 5 months of tonsillectomy and complains of throat pain to you. What will that make you think? What will you think of at this point? First of all, it could definitely be a case where there is a residual tonsil tissue which has been left behind, and this usually happens in the lower pole area. Second, obviously, it can be any other causes of throat pain like pharyngitis. Next, coming to what are the complications of tonsillectomy. When you are asked about complications of tonsillectomy, always divide it into two: the immediate complications and delayed complications. Immediate complications include primary hemorrhage, reactionary hemorrhage, injury to structures like the tonsillar pillar, uvula, soft palate, tongue, or superior constrictor muscle, injury to teeth, aspiration of blood, facial edema, and surgical emphysema. And delayed complications include secondary hemorrhage, infection, lung complications, scarring in soft palate and pillars, tonsillar remnants, hypertrophy of lingual tonsils, and something rare known as Grisel syndrome. This here, the most important complication that you would have to remember are the different types of hemorrhage that you can see post tonsillectomy. Let's discuss each one of them in details. First of all is primary hemorrhage. When do you see primary hemorrhage? Primary hemorrhage usually occurs at the time of operation. And what is the cause of primary hemorrhage? It could be because of an improper ligation or cautery of vessels. There could be a slippage of ligature or an injury to a tonsillar branch of facial artery or any other nearby vessels. And how will you treat primary hemorrhage? Usually, we ligate the bleeder or use electrocautery. Next is reactionary hemorrhage. Now, when do you see reactionary hemorrhage? It usually occurs within 24 hours, but most commonly it's seen within 6 to 8 hours of the surgery. Cause is mostly due to either slippage of ligature or a presence of a clot. Now, your treatment will be directed to removal of the clot, applying pressure or vasoconstrictors, and giving hydrogen peroxide gargles. If this fails to improve this case, in that case, you perform a ligation or electrocoagulation of the bleeding vessels. Now, as a duty doctor, when you're doing rounds in your post-op ward, what are the signs you should be looking for in the patient that will point the diagnosis towards a reactionary hemorrhage? The patient will be tachycardic. There will be a low volume of pulse. Because the patients they're not aware of what they're doing. They're pediatric patients. They'll end up swallowing up a lot of the blood, so there'll be repeated swallowing that you will be noticing in the patient, and later all of this blood that they have swallowed up, they'll end up vomiting it out. So these are all the signs that you should be aware of in a post-op case of tonsillectomy in the ward. Now, the third type is the secondary hemorrhage. Now, secondary hemorrhage, it usually occurs between 5th to 10th post-op day. And the cause over here is not any clot or any ligature failure, but rather it is the result of infection or sepsis. The patient will come to you with a blood stained sputum. So, here the treatment will not involve taking the patient up an OT and exploring, but rather you'll start the patient on IV fluids, IV antibiotics, and blood transfusion. And after all of this, even then, if the bleeding continues, in that case, you can do a pillar to pillar suturing or an external carotid artery ligation. Now, a very important question over here will be, how will you differentiate between external and internal carotid artery, because they follow a similar course? So, the way to differentiate is that the external carotid artery gives off branches in the neck, whereas internal carotid artery does not have any branch in the neck. So, the moment you see a branch coming off in the neck from the artery, you know that that is the external carotid artery. Lastly, one last question is, what is Grisel syndrome? This is a delayed complication that we see in tonsillectomy patients. Grisel syndrome is when a patient comes to you with neck pain and develops torticollis. The cause over here is because of the position in which the operation is done, there is a spasm of paraspinal muscles and atlantoaxial joint subluxation. This is more commonly seen in patients who have collagen vascular disorders or Down syndrome. And Grisel syndrome has a higher risk of developing in adenoidectomy cases and a lesser risk after tonsillectomies. So, that is all about our case discussion today on tonsillitis. If you have any other doubts regarding this or any other questions you might have, any Viva questions you might have regarding this, please note them down in the comment section and I'll get back to you. Thank you.